All right, so today we have two panelists. I've got Kathy Greenlee and Carol Buller here. I'm also joined by my colleague, John Carney, who will be just sort of participating as an additional panelist. So today we're going to be talking about COVID-19 in nursing homes and kind of what's going on and like the challenges that they're facing and why those challenges are taking the shape that they are. So Kathy Greenlee previously served as the U.S. Assistant Secretary of Aging, Kansas Secretary for Aging, and Kansas State Long-Term Care Ombudsman. She has 25 years of public service experience. When she returned to Kansas from her service in Washington, D.C., she was a health and aging policy specialist at the Center for Practical Bioethics. Kathy is currently working by contract as the Kansas COVID-19 Long-Term Supports and Services Liaison. And Carol Buller is a gerontological nurse practitioner and clinical assistant professor at the University of Kansas School of Nursing, where she is coordinator of the Adult Gerontology Nurse Practitioner Program, teaches care of older adults, advanced care planning, and palliative care. Dr. Buller has been in a private geriatric practice and rounded in skilled and long-term care facilities for over 16 years. She holds certification as a family nurse practitioner and a gerontological nurse practitioner. Her clinical interests include caring for persons with dementia, weaving palliative care into geriatric practice and advanced care planning. She is a member of the leadership team for the Kansas-Missouri Bi-State Coalition for Transportable Physician Orders for Patient Preferences, otherwise known as the TPOP initiative. So we work with Carol on that and also have worked with Kathy on that in the past. So let me set up the screen share and then I will hand it off to our guests. All right, are you seeing those slides?
There we are.
Okay, great. And Carol and Kathy, take it away.
All right, this is Kathy. I will jump in first. I'm pleased to do this with Carol. This is a nice thing for us to be able to do together. As a setup, I just wanted to describe kind of our orientation to this presentation. Carol and I come from different backgrounds and different professional histories, and we will present this to explain what we think we are seeing. This is more of an observation about what's happening in nursing homes, why. We haven't set this up to be a critique. That's certainly easy to do, but we want to just talk about, the dynamics in nursing homes, the history in nursing homes, the care, and how we interpret the news headlines. And so I had Matthew pull some news headlines, and they're the ones, if we could flip to that, Matthew, they're the ones that just break our hearts. Here and all over the country, so much of this death is taking place in nursing homes. And it's not just residents, as this headline says, it's workers. The House and Congress is programming nursing homes. There will be a lot of after-action discussion about why this is happening. There's blame games happening. It doesn't really help the situation on the ground at the moment. New cases rising here in Kansas City. And the top headline that this is really 1 in 4 of the deaths. So it's just devastating, and you can't be a human and not be impacted by the toll. It's really what motivated me to see if I can help with the state of Kansas at all. So let's do some data, Matthew. I pulled this from Kaiser Family Foundation website. They pulled this from the reporting that's happening to both CDC and CMS, that the long-term care facilities with known cases at this point in the United States are almost 10,000 in 44 states. The confirmed cases are 204,000, as you can read, and the deaths, 50,000. And these numbers will grow. The current deaths in the state of Kansas are 134, Missouri 305. We put an asterisk on that because we can't find as current data about the deaths in Missouri. There's more population in Missouri. The death counts are a little bit higher there. But these are just tremendously disturbing, and they will continue to grow. And at some point, it'll be everywhere, I think, in all 50 states, of course. Matthew, let's go from there. I wanted to talk about this slide that just came out from CMS within the last week about COVID-19 cases and people who have Medicare and people who have Medicaid who are dually eligible. This is primarily an older population, but not exclusively. There are about 8 million people on Medicare who are there by way of being younger with a disability. It's predominantly an older population. And what I want to show you and make sure you see on this slide is the yellow. That the yellow people in this slide are the people who have Medicare and Medicaid. And the striking difference in the impact of COVID-19 on people who are poor. Older people who are dually eligible represent a couple of different groups of people. People who've been poor their whole life, who age, people who grow old and become impoverished because of their need for long-term care, who spin down to Medicaid. It's a little bit of both, but it's always higher here in terms of the prevalence in the cases among people who are dually eligible. The bottom left of the chart also shows you just the racial disparities that we're seeing, the prevalence of the virus and the impact of the virus on people of color. If you adjust for the percentage of the population, these are extraordinary numbers. Even in Kansas, I was looking at this data recently. There's like the population of Kansas, like for African Americans, is like 4%, and the deaths are 25%. I mean, it's just really striking. And then, of course, the last one on the bottom right, where the cases and the deaths are occurring. People over the age of 85 are at huge risk. I was just on a presentation by the Kansas epidemiologist, and she talked about the death rate in Kansas. Of the deaths from the virus, 78% are over the age of 65. So we're seeing increased prevalence among younger people, but this is really much more fatal for people who are over 65. Next slide. So I'm going to switch to Carol and spend a few slides talking about who's living and working in nursing homes to give you some sense of their profile a bit.
Sure. Thank you, Kathy. This is Carol. And, you know, nursing homes have changed over the last 20 or 30 years. We are seeing older and sicker people coming into our nursing homes. And of course, because the age is lengthening, we're seeing, like I said, the oldest old. And most of these individuals need assistance with activities of daily living in addition to healthcare and managing meds, managing therapies and such. The age is increasing, and along with that is a higher risk of frailty. Frailty in and of itself is a risk factor for those who do come down with COVID because they may present with atypical disease. These individuals may be more likely to go to the hospital, experience functional decline, and if they do return, they will need ongoing support for a long time. Many older adults, and I would say most, in my experience and practice, have an underlying chronic condition such as hypertension or chronic kidney disease, diabetes, lung conditions like COPD. And these chronic conditions are more likely to occur in those who are dual eligible, those who are on Medicaid as well. COVID in older adults, as many illnesses in older adults, may have an atypical presentation. And so those early symptoms may not be the typical symptoms that we would see in younger adults, and early symptoms may be missed, or they may not be tested. And then when having the unrecognized infection, of course we have risk for future transmission, and we've read those in many articles. We've seen that in the news too. I would say that going back to when the first cases came out in Seattle, I have family members living in Seattle, so I always perked my ears up to that. And I thought to myself, you know, they probably checked for influenza on these respiratory infections, and these people were all negative. And then all of a sudden, they had these older adults in the nursing facility that were acutely ill and needed to go to the hospital. It's not because they didn't recognize, it's because the infection was so different than what they had seen before. Okay, Matthew, thank you. Next slide. And then nursing homes have a high percentage of people with dementia. And these individuals, of course, cannot care for their own hygiene. If you would give them a mask, if they were a person who would walk around and you needed and wouldn't stay in the rooms, they would not tolerate masks. They can't follow hand hygiene. They pose there's different considerations to do with performing nasal testing. Nasal testing is not comfortable, and I can imagine what it would be like if I had dementia and someone who was completely garbed up came at me with a swab to stick up my nose. And then in-room isolation is really challenging for someone who's very confused. And it's hard for me to imagine how difficult this would be for persons who are used to walking around and moving around their environment. Again, families and visitors not being able to visit is a concern for all, because it's more difficult for families to be the eyes and the ears. There are many times when families are the first to spot changes in their family member, the first signs of infection or the first sign that something is different, and yet they're not able to provide that information. And some residents rely very heavily on the care and support of family visitors. Next slide, please. So staffing, and Kathy's going to talk about this a little bit more in a future slide, but staffing and staffing ratios are always an ongoing concern in long-term care, and they were pre and during and post-pandemic will continue to be. Direct care staff are often very low paid in comparison to the same type of care provided in the hospital by nurses' aides, and the result of this is that they may be working in many different nursing facilities. They may have 2 or 3 jobs, and that increases the risk for them to contract COVID or to be able to asymptomatically spread this. Some staff members are employed by the provider, others are hired by staffing agencies. When you have people who are coming in from staffing agencies to staff a place, they don't know the residents. They certainly don't know the routines and the procedures at that organization. And so care can be more fragmented. And then staff transmission has likely been the most primary source of the coronavirus introduction to the facility. And that would be asymptomatic staff members who come, but also staff members who cannot afford to stay home because they don't have any sick leave pay for this. In many places and in many major cities, staff rely on public transportation, and it's hard to have social distancing in that situation. Next slide. I'm sure by now staffing are working double shifts and longer shifts because there is less staff, or when staff are out because they have to quarantine. They will oftentimes work 8 to 16 hours at a time. And as we said, quarantining the exposed staff, of course, reduces the number of available staff. And I already mentioned that there is no sick leave for many people. They don't get paid if they don't work. The other thing is that a perception in nursing homes are that we should be able to provide for people, provide that support in place, but these staff are not trained to provide for someone with a serious respiratory illness. And they unfortunately may have limited training in infection control, and they're not nearly as familiar with the PPE as those persons in the hospital, as well as not having the PPE available. Next slide. But this is home. For our nursing home, our assisted living residents, this is home. And we, I think the industry has done a lot to try and make this feel less institutional and to make it seem more like a home or a community environment. And people don't want or expect to feel like this is in the hospital. Even though there are hospital-type beds in the rooms are often decorated to be more homey and also to include important mementos and reflections of the person's life. Person-centered care came into vogue probably in the 90s when I started to hear about it. And it really focuses on those twin goals of quality of life as well as quality of care. And many organizations are really striving to develop that person-centered focus. This COVID virus has totally taken that away. Social interaction in a person-centered care facility or person-centered care is really important. And the community is important, and so there's communal dining, interaction, and group activities. And participation with the family, from outside volunteers, from pet therapy is really encouraged. So this has been a huge change for these folks who are sheltering in place in a long-term care facility. Next slide.
Yeah, maybe before we move to the next slide, I'd just like to mention that it's interesting that you call out the person-centered care focus here, just because over the last dozen or so webinars that have come up, we've had this same comment made by several of our guests. They've all sort of commented about how the past couple of decades we've spent emphasizing the importance of person-centered care, and then all of the sort of frustration and anxiety that comes up around this scenario, which makes it impossible for us to continue providing care in that mode, that we suddenly have to think about it in terms of scarce resources or like overextended staff and things like that. And I just think it's interesting that this same theme just keeps coming up for people.
So Matthew, I want to chime in before we move on. A couple of the major kind of tenets that support a person-centered care is choice of the individual and their rights. And, you know, if you just walk and breathe and read the news and you see so many people in the public, not in nursing homes, being resistive to any sort of direction, like wearing a mask or staying home. I mean, Americans really feel strongly about being able to exercise our own autonomy. Nursing home residents do not feel that less. And we have really worked hard over the years to make sure that nursing home residents have some autonomy and control and decision-making in their own life. A pandemic by necessity, and this one that's so infectious, takes some of that away immediately because of the goal of quality of care under the auspices of safety. And it's really challenging because one of the requirements, and I'll talk about this a little bit more on the physical plant, is that nursing home residents be separated based on their status of whether they're COVID positive or unknown or negative. And they lose a lot of choice, the residents do at that point, about where they're residing. And yet that's one of the fundamental rights that residents have. So there's a real conflict within facilities at the resident level about what they've lost in terms of their own autonomy, all with this motivation of safety, which is really tricky. It's both true and problematic, I think, at the same time.
Yeah, well, and it comes up with staff too, and the moral position that it puts them in, right? When they've been taught to provide care in this perfect person-centered mode, and then they're told all of a sudden it's like, okay, we have to completely shift gears, right? And we have to think about this in a completely different, or using a completely different scheme. And I think that can be very hard.
Yeah. I wanted to then also just talk a bit about quality of care and the good providers. If we go back to the very first headline, where Congress is looking at poor performers, you know, people need to be comprehensive in seeing what's happening. There are good nursing home providers. I've been in good nursing homes. They do exist. I think they typically have more nursing aid staff that are well-trained. Good providers will have the coronavirus. There are poor performers. They will now be subject to a lot of focus. Special focus facilities in CMS parlance are nursing homes that have performed so badly on state licensure inspections or survey inspections that they get inspected more often because they just really don't deliver very good care. And the 1- and 2-star CMS has a 5-star rating system. It's more guidance than sort of determinative, I think, but it's a resource for people to go to if they want to know more about a facility. The facilities to get a 1- and 2-star rated, which is the low end, they are not pre-positioned to handle the coronavirus well. And I think as we look, whenever this is over, we'll be able to see that in the data, that the poor performers will really struggle. That does not mean this is only about poor performers. And I think it's too short-sighted to not look comprehensively about what we need to do with infection control. And the history of infection control is a really big indicator of what people know, and historically the ability of the facility to to do infection control well, I was just before we started, like this morning, looking at a story coming out of Baltimore where a nursing home there who has 0 cases at this point jumped on infection control early, like before this was declared by CMS or CDC or even the president, and hired a new infection control specialist. That this is the heart of what the pandemic is revealing. This is so highly infectious. So I think down on the response, then repeating myself a bit, that this is not as simple as good and bad. That the speed of response is really what is saving lives. Nursing homes must be able to cohort residents quickly, and the guidance has come out from both the state and the feds about moving residents, and this is what touches upon some of those rights issues. If you've got residents who have roommate and one's positive, you assume they both are, and you treat them as such. And staff testing and resident testing is essential to make this decision. And everyone has to be presumed positive until they can be found and tested to be negative. It's that infectious. And community transition is an important factor. We have a lot of outbreaks in meatpacking facilities in Kansas. It's not a surprise that when you pull up the Dodge City Telegram, that the nursing homes there have outbreaks. The nursing homes south of there have outbreaks. That in communities that have outbreaks in prisons, large employers, meatpacking, general community transition, those are the places where the nursing homes need to be especially vigilant early and test everyone because you cannot, these individuals are living in community, being staffed by people who live in community, and it's such an important factor. Coronavirus is also found in rural areas and urban areas, and the 3 kind of clusters that you can find in rural parts of the country are the ones I just named: nursing homes, prisons, meatpacking. And those all have people who are staffed in the community. Often, unfortunately, these people can be lower wage as well and really at risk if they're not able to go to work. So it's important to talk about quality. It's all over the place in terms of how providers were pre-positioned to handle something this sudden and this bad. I'm looking at, Carol's talking about families. I'm just going to respond to Carol's comment, and then we can all jump in. That families were okay with closing facilities at first. We're seeing frustration. I'm reading more about family visitation as well. Carol, I agree with you. And what I'm reading, it seems like that the balance has shifted a little bit. That and I think nursing home residents are no different than the rest of us who've been staying at home, which is at some point this is a long-term problem. And the long-term impact of residents not having family visits is just really horrible. First of all, we need more people in there to see them, to see what else is happening. There's risk if no one comes in that facilities will increase their use of chemical restraints. You could have more abuse. And you can just have residents who really, like Carol said, really need the connection to their families and families to them. This is an important period of life because most of these residents are closer to the end of life, and to have family is really important. I'm going to read John asking.
Yeah, how do we respond to the claim that it's just natural that older people in long-term care should be expected to predominate on the number of deaths due to COVID? We get used to seeing large number of older persons dying during the flu season. Why shouldn't we be okay with COVID reflecting the same results?
John, you don't get to ask any more questions. They're too hard. Carol, do you want to, I can jump in.
That is true because the persons in nursing homes are at the highest risk of our population in getting an infection like COVID or influenza and dying from it. And it will happen, but it doesn't, but we still have to try and prevent that from occurring and minimize the number of deaths.
So John, I think the challenge in here is we must not assume that this is the best we can do in providing settings of care for older people. This is what we built. This is what we've paid for. And just expecting older people to die, they will die now here because of all of this that we're witnessing, trying to walk through. But there's a great deal of ageism involved in assuming that older people are going to die. They die of the flu, they're dying of this. But this is really unprecedented in terms of the lethality, the long-term healthcare outcomes. And we really should not settle for this being okay. Without trying to sort of just ride a wagon around with blame, but we should not as a society think it's okay that we have congregated people in settings. They're not prisons. Congregated people in settings to deliver care in those very settings pose a risk for them. We need to keep those issues in mind as we move forward, and I'll talk about that here.
And it seems to me too that during a flu season, we usually have prophylactics available, or we usually have a vaccine, at least an attempt to have a vaccine that matches the needs. And we don't have that now. So it would seem that where there would be, as you say, a commitment to greater caution and greater protection, rather than just being comfortable with the fact that, well, a lot of people are going to die because it's a bad thing. But we don't have those normal routine kind of approaches to helping us deal with this outbreak. And so it really calls us to greater vigilance. I agree with you.
Well, and I mean, my panelists, many of the people probably listening know, I just feel very strongly that we continue to make a division between us and them when we're talking about older people. And this could be the future for any of us or our loved ones. Many of us have loved ones in nursing homes now or in various congregate care settings. We could end up being in one of these settings ourselves in the future. We're not protected from a second pandemic or a next pandemic because of this one. Carol has talked about that there have been infectious disease and kind of smaller crises that have come through nursing homes in terms of a more novel virus. And this will happen again, and just accepting that this is what's going to be okay. It's just ageist. Someone is just basically ageist. All right, let's go on. I want to talk about the building. Most residents in nursing homes in this country live in semi-private rooms. There are still a few places you will find where people live in 3 and 4 bed wards, we used to call them. And it's just horrible. But most residents are in semi-private rooms, which means you have 2 people receiving care from aides who may or may not be the same aides, but you've got twice the risk. That infection control really would be less of a challenge if residents were in private rooms. But resetting a facility to accommodate private rooms would have a huge financial impact on the building and on the provider, because you would have half the census in the rooms and you would have decreased revenue because of it. So, these are the kinds of issues. When we look at what's happening, it's like, oh, everybody's in a semi-private room for the most part. Yeah, that's going to be hard to fix. And we were talking about the need to separate residents and test residents and cohort them. The physical size and layout of a nursing home right now in dealing with this pandemic also impacts their ability to move people around. Certainly there's support for what I think of as the licensure side. CMS in the States are supporting nursing homes if they need to use previous areas of the building that were not resident care and flip them to resident care. If you need to use the dining room for resident care, then whatever you need to do right now, you've got to cohort the residents. And bigger places will have more options for cohorting than smaller places. Nursing homes that have previously had people come from the hospital to receive their Medicare rehabilitation for broken hips or surgeries may have a separate wing that they could then use to cohort. But if you have a small facility, you end up with some challenges of those small size of the physical plant. But if you have a few people that you're cohorting, they must have dedicated staff. This relates to staffing. If you have a building of 40 residents and 2 people who are positive or not known to be negative, they must have their own staff. And the laws of small numbers then just become more complicated because now those staff can't care for the other people. They must care here. So there's some issues just with regard to the types of places that people are living in. And this is related also to what Carol was talking about in terms of us really working to create living environments that are home, not hospital-like, and that can change things. Let's see, Jeff is, yes, this is not the best we can do. Let me see what else I want to cover here real quickly besides the building. Matthew, what else did I put up next? oh, money, this is my favorite slide. Yes, everybody laughs because they know this is my favorite slide. You know, what we get what we pay for, always and anything. Medicaid is the single largest payer for long-term care. It's so expensive. Medicare is only paying for some rehab, and facilities really rely on it because the reimbursement rate is higher. But Medicaid is the single largest payer. And this is essential for us to understand as we look for solutions. The world is also different in nursing homes with regard to who's providing care for the poor. And I have talked about this publicly for a long time, that in this world, it's the for-profits that have the higher census of people on Medicaid. The nonprofits typically have Medicaid residents, but they typically have fewer in percentages. That the bulk is really coming from care delivered by for-profit, which may be huge companies, multi-state companies, publicly traded companies. They have higher census of Medicaid. So that first sentence, that first line should reveal to you the problem. There are individuals with the profit motive trying to pull a profit out of a census of people who are on Medicaid. And this just sets up a potentially bad dynamic in terms of making sure that you have sufficient money to provide the care. This care is expensive, and there are for-profits. I'm not trying to diss all for-profits, but there's a reversal here than what the public thinks of. They're used to nonprofits being the ones providing the food. When you go out and look at the food line right now, those are nonprofits trying to serve the needs of the poor. For nursing home care, it's the opposite of that. You've got a for-profit system that's really struggling sometimes with insufficient rates from state Medicaid programs to provide the level of care. This is expensive to provide. If we were to improve the settings of care and the delivery of care, it would have a huge impact on the Medicaid budgets. I was on a call with someone 2 weeks ago who said easily, you know, we need to raise the salaries. We absolutely need to raise the salaries for everyone working in a nursing home. We need to improve the staffing ratios. Every quality survey you've ever seen or every study you've ever seen talks about the relationship between sufficient staff and quality of care. We would be better able to contain virus and infection in private rooms. All of those issues will depend on an increase in the state Medicaid budget. And the state Medicaid budgets and the state budgets are about to tank. That we will see drastic state budgets in the future, drastic cuts coming. And Medicaid is countercyclical. At the time things are the worst in the economy, you have the most people who need Medicaid assistance. This will not be easy to solve, even though the problem is so obvious in front of us all on what we could do to make a difference. There are also currently real-time expenses to providers in trying to staff up, to get the PPE, to provide more care. There's just costs right now that providers are experiencing, and they are reaching out to relief from both the federal government and the states to get a bolus of cash right now to help with the care, which I think is quite legitimate. It's also problematic long-term because the payments for nursing home providers are typically retrospective. You send in your costs for the last year and we calculate your rates. And right now, there's a huge kind of drain on those expenses, which is what makes the real-time relief so important. And then also to just kind of go back to the slide that I had earlier about the Medicare dual demographic, that the nursing homes with lower quality ratings caring for Medicaid or racial and ethnic minorities have had more confirmed cases. Carol, you added this piece in. Do you want to add more about what you looked at on just the care? I mean, and this is obvious also when you start looking at sort of the demographic makeup of some of the
right.
people.
Some of the early studies.
Yeah, such bad outbreaks.
Yeah, some of the early studies that have come out with COVID are showing that the lower quality ratings showing exactly this that you've talked about. And I think this was in the journal of in JAGS, Journal of American Geriatric Society.
Yeah, these are all related. What else? I mean, we can talk about money for a long time. It's going to be hard to solve this problem. Matthew, what else do we have coming up? Our position on transparency when there's an outbreak. Oh, I have an opinion on about everything, John. I come from such a long time serving in public service that I really do believe in transparency. I think it's best if the public know. Certainly family members must know. That's not even like a debatable issue. But telling the public where there's outbreaks. What's happening now, and Matthew talked about me doing the contract work with Kansas. What's happening right now is a clash of systems, just in terms of some underlying just values in the systems. That the pandemic is a public health response, an emergency management response that's primarily functioning at the county level. And historically, public health has been very reluctant to be to provide public information because of the nature of what they've been doing. If they're tracking an HIV outbreak, and there's like 3 in a county, becoming public, there's not a way to keep that information anonymous, and being public can actually quickly out someone for whatever it is that they're doing their tracing and their contact tracing. So there's a kind of a closed nature and a real sensitivity to personal health information and publicity within a public health structure. So you'll see counties historically have been doing this different. Johnson County has become more transparent, I think, recently here in Kansas City. The nursing homes are now all required to report up through a healthcare and health safety reporting system up to the CDC, who's now making that information public. It's kind of hard to manage and go through their data because it's kind of big and wonky as a database. But you will start to see more of this information become public because of the national reporting. I personally support it. I'm sensitive to the fact that that you do have to make sure that you don't reveal one person, but I do think there's a way to get this information out there. I think it should be there.
So is that the objection from the provider side? Is that that the information being shared with the public would identify or do some type of HIPAA violation by the fact that people know who these folks are now? And is that the argument on the?
I think that's the value. I think that's the value base from which public health is operating. Obviously, if you have an outbreak with 70 people, you can just say 70 people. It's de-identified. It's like everybody. But I think the value base in public health is very much from a position of privacy and respect for privacy. And I understand the reason for that, but it is it is kind of a different time when you have this much of an outbreak everywhere. But it's kind of the public health.
It's like a path.
Value, John. Yeah.
It's like a path dependency sort of thing. Like if this is the way that they've done it in the past, why would they do it differently, even if the circumstances are a little greater?
Yeah, and it's not that can't be overcome. It's just they're not used to doing this.
Right.
They're not used to being public. They're not designed to be public. They usually have really private information. And now we want them to be public, and I think they should be. But I think it's kind of like, we have to be public. But it's not automatic for a public health system. They're just not geared in that way historically. It's not that I think they shouldn't be now. They have to. There's conversation to be had there, so that it becomes public. It's not automatic.
Yeah, it's interesting because then they would be in the position of having to come up with like what that actually looks like in practice, how those numbers would get published, where they would go, and then if they don't have sort of standards and protocols already in place for that, that's all stuff that they would have to develop on the fly.
Yeah, it's just not natural for them. And if you think about the law of small numbers, you can see where the sensitivity would be particularly acute.
Yeah.
But
I know that objection even came from public health. I know that the new public health director for the Johnson County in Kansas, initially when there was a demand by families that they be more transparent in terms of where the outbreaks were, his response consistently in the newspaper for weeks on end was that that's not the way we do it in public health. We have relationships with these facilities or employers. We work with them very, very quickly. We try to respond to their needs so that they can address it. And that this, if we reveal this information, that somehow there'll be public shaming, and then that'll only deter our ability to be able to provide them the support they need. So it's kind of this, wicked little reversal of what we think would best happen by the fact that these people then become, if you will, in some cases, through no fault of their own, an outbreak occurs, and they're just trying to do the best thing. But at the same time, once the public finds out about it, then it's, you know, they're the bad guys.
Well, and you know, when I just started contracting with the state at the beginning of May, I also will assume that providers have a vested interest in this, but I wouldn't assume that it's always that they don't want the information to come out. I mean, they obviously have an interest here, but transparency about what's going on if they have an outbreak is actually a better way to manage community engagement, to tell family. I mean, more information here is better than less. So I don't think we should just automatically assume that the barrier here to transparency are the providers themselves sort of as a block. It'll be provider to provider depending on the facility and kind of where they are with this. I think, you know, that certainly could be a factor, but I think it's more driven right now by public health because they're the ones who would have the data to release.
Well, and
it's not the facility from coming public themselves. I mean, I grew up near Wichita in the small town of Clearwater, where they've had a tremendous outbreak. It was a one-star facility. They've had 9 deaths, and they've been very transparent, and Sedgwick County has kind of talked about that as well. So it can be very specific.
And kind of staying with that theme, I noticed that there's been leadership at the national level and state levels from the state associations that representing long-term care, that they want this information to be out because it also points to the issue of the lack of PPE and, you know, the personal protective equipment that is long-standing. I mean, we still don't have the proper levels of equipment and personal protective equipment for long-term care facilities across the United States. And it's like, and they can't go anywhere to find it, to get it. And so there's this additional vulnerability that they have for a very, you know, high-risk population, and virtually limits in terms of how they even protect that group. And they want the information to be out there to say, we're doing our best to find it wherever we can. And it's still not enough because we just don't have what we need. And I found that to be, you know, kind of not surprising, but certainly a sympathy. I have developed some sympathies for those organizations in that process to say, you know, we got short-changed here from the get-go. And it's hard. It's really hard to do this well when you can't even provide your own staff. And as Carol said, I think in the earlier slides, many of those people relying on public transportation, multiple generations and their families when they go home at night, they really don't have the ability to know for sure that they're not re-exposing themselves to risk when they go back to work the next day and might be asymptomatic. It's kind of this vicious, ugly cycle in this whole, you know, insidious illness.
I think this is quite obviously an editorial comment for me, as if the others aren't, but I think the other problem with not being public is we really do need community support for nursing homes, both the residents and the staff. This is not something people invited in, good or bad or whatever the quality. This has happened to them now. Their ability to respond is what we're talking about. But I cannot imagine the hell of working in a facility that has an outbreak when people are doing this work because of their care and concern about older people and the people they're caring for. And part of what we need is to pay attention to what's happening, to deal with the policy, the health, the PPE, but the people impacted on the inside, and the gratitude. And we don't have to be thankful that people are dying, but the gratitude for the people who are doing their best to provide care needs to be expressed, just as it is in hospitals. There's lots of reasons why there's problems, but blame right now is actually not going to help as much as getting more assistance and shoring up the people who are there.
Can you talk a little bit too about the need for reopening to reintroduce families? You know, we've lived through 3 months, 4 months worth of, you know, complete separation and a lot of really awful kinds of things with the fact that we're not very good at, you know, the intimacy isn't there, the touching, the care is not available, not only from the staff, but even the families. So, and I know there's a move now to say it's time to reopen for families. Can you talk a little bit about that, what the risks are, what the concerns are that you have, or that maybe the benefits are to families and those that live in long-term care?
I agree with the initial policy guidance because we didn't know much about this virus. It's only 3 months old for us, or 4, so we're only that far into it. But it's like, it's coming into the building, we got to stop it. And that's sort of the underlying rationale initially. It's like, we're going to stop everybody from coming in. and figure this out. And we know now that the most likely pathway for transmission is from staff. And families need to see their loved ones and vice versa. So I think it has to do at this point more questions being raised by advocates for residents, and some of those advocates are their care providers, the medical directors that we really need to reunite to people. There's a value and just a quality of life issue there. At some point, it becomes inhumane, and I think that is what people are starting to question now. It's like, okay, this is where we are. We need to take precautions with staff. None of us want to be silly, but we cannot assume that this is any way permanent, and it's probably time to challenge what's the next step. And CMS just issued guidance yesterday to facilities, and it still depends on what's happening in the facility in terms of how active the cases are, but it is time to be specific about taking steps forward. The compassionate care exceptions have been too narrowly interpreted. I mean, people need to see loved ones, not just the last hour before they die, but people who are decompensating because they haven't had family members in, people who have a few months to live. You don't get just an hour. Someone has a few months to live. And that facilities can really be creative with their own outdoor spaces. I mean, many facilities have outdoor areas. I don't know how you're going to do that when it's 105, but you have to get some of those cooling fans. But you can use your outdoor spaces. People still need to be protected. They need to not be able to touch each other. But let's start with what we have. It's like the rest of us in life. What can we put back, and how does it need to look? And it's just really time to talk about this more, not less, and say, okay, I don't know that time's up. I think that's too naive, but we got to take the step, and now's the time to ask what that step is.
Carol, could you follow up a little bit on the clinical side in terms of with the kind of this intimacy issue around advanced care planning, choices not to shelter in place, not to go to the hospital, not to go on a,
let's do the next slide.
Oh, I'm sorry. Okay.
Well, I think this is the perfect setup. Yeah, what Carol would like to see right here.
Right. Well, studies show that RN staffing is very important in long-term care, and I would say that registered nurses and nurse leaders like BSN nurses should be, their staffing levels should increase, because RN staffing level is associated with fewer cases and deaths, and that's true in other type of infectious diseases too. And then thinking of early advanced care planning, I know way back in March when we first started sheltering in place, or even before that, I thought, oh my, if I would be making nursing home rounds, I would be starting to target everyone at some point in time to talk about wishes and preferences, to talk about it in terms of, hey, we're in this situation that's not looking good if people get COVID, and we need to know what you would like at this time, and talking with families. And that could be done over phone or with Zoom, but just spending the time to talk about what's most important. Not, do you want to have go to the hospital? Do you want a breathing tube? Do you want IVs? Not those specific things, but really what's most important for this person. And if their family knows what that is, to communicate with them on that. I'd also say that I feel very strongly that we need to, as a public, provide some grief and social isolation support, not only for the residents, for the individuals who are living in long-term care and assisted living, but also for the direct care staff who have been through a traumatic experience, and really losing, if they've lost different residents in their setting, if they've seen people go to the hospital and not come back. That's really important to provide those type of resources to them as well. I think facilities need to realize that this is not a once and done, that this is going to circle around this winter, and I mean this fall, this winter, and so if you haven't developed your plans, you had a good try right now, you need to develop emergency plans and protocols and begin amassing resources again, because it's going to be important to be prepared in fall when influenza comes, and also when COVID makes another return too. Training of the staff is important, both with PPE, but also training people to take care of individuals with respiratory problems or at end of life too. And then also, I really appreciate the fact that telehealth has become important for providers, for medical providers, as they can make visits to individuals, their residents, but also to nursing facilities. Many of our medical providers are seeing residents in multiple homes, and so that's not a safe situation for them to make just blanket visits to a facility. And so I think that telehealth will continue to have an important role in caring for older adults in long-term care, even after COVID completes its rounds. I'd like to suggest that long-term care facilities build partnerships. You know, hospitals can provide training on PPE, on infection control, but also academic partnerships. In my organization, we have doctorally prepared nurses who are working on major projects in quality improvement, and having a partnership with an academic institution would be really important. And then I guess lastly, I'd like to say, having been in rounding in nursing facilities and feeling like I was a second-class provider because I was taking care of older adults, I think we need to offer and extend compassion to our workers in long-term care and assisted living and any aging type of service, because it's a difficult job, and I believe that many of them, the majority of them, are doing the best that they can in this situation. So those are my thoughts.
I think mine have to do with money. Will you be surprised? I think the policy changes, like I mentioned earlier, that could improve care will be really difficult. And it's because so much of this is connected to the expense and the payment of care. And like I mentioned earlier, that the state budgets, you should connect those when you read those headlines, this issue of the state budgets. I am hoping that the crisis that we're experiencing will provide some impetus to discuss again the need for some long-term care financing reform, including a long-term care benefit for Medicare, because Medicare does not pay for long-term care. And there have been different attempts at this. And when I was at Health and Human Services after the Affordable Care Act passed, I spent 18 months trying to establish the CLASS Act, which is the limited benefit long-term care program that was a part of the ACA, and it wasn't actuarially kind of feasible, so we didn't create it. Whenever this issue comes up at the federal level, we need to plan for how to pay for long-term care. Almost everyone's going to need it. The price tag becomes problematic about adding a benefit to Medicare. My pipe dream would be, and maybe I hope it's more than a pipe dream, is that maybe we've gotten used to some of the big numbers, and maybe the big numbers of deaths and illness in nursing homes will facilitate a conversation about that the financing of long-term care needs to be a federal conversation. Can Medicaid help? Can Medicaid expansion help? Yes. I mean, Medicaid, John, this is John's question in the Q&A. Medicaid expansion could absolutely help to cover people just above the poverty level that we see now, and the racial disparities that we've seen so much of. But for long-term care itself, this has to come back at some point to Medicare. We need to, and if we did that, if we could find a different way to have a benefit through Medicare, we could come up with different mechanisms to support people so that they can age in place and not in a nursing home. This is what everyone wants. All of us know it. It's what we want as well. Often people are not able to age in place because they don't have the financial means to do so. And sometimes the financial means would not be extraordinary, but some more modest assistance. The longer you can help someone age in place, the more likely people will meet their own goal and die in a community. So it's worth it to add, let's just add 2 years to someone aging in place. I mean, it can just help with people where they want to live and not going to a nursing home. I have never felt that we could or should operate a system completely devoid of nursing homes. I would certainly like to see us change our approach, change how we deliver the care, change how we pay for them, but many more people. It really should be kind of a last stop for people. The other thing that is really wonky is that we need to regulate the corporations. We don't regulate the businesses themselves. The government regulates how we pay for the care and the delivery of the care. And on the delivery side, we continue to add more and more regulations because the care is so complex. You'll see a lot of attention now to infectious disease control, but we really don't have the corporate entity. No one regulates the corporate entity. I regulated insurance for 8 years at the state level. We regulated the whole entity. We could look at the whole corporation and say, you're getting profit here and there and everywhere. And the corporate structures that support this delivery of care are complicated. There are private equity investors. There's that perverse incentive to make money off Medicaid. There are people who quite literally buy a nursing home because they want the real estate speculation. That we really need to look, and this would take federal look, to look at the corporations themselves. There are providers and administrators and DONs out there who know that if they had more staff, if they could have if they fixed the air conditioner or the back door, that they could provide better care. And how do we make sure that the people who own these are accountable to investing in the staff? And I just think it's odd that in this very fraught care delivery system that we are regulating two components, payments and care, but not the business entity itself. And that would make a huge difference. And I don't know that that's possible to achieve. It would be so politically challenging at the federal level. It would be, yeah. Those would be controversial hearings, but we don't regulate them that way. Well, I think that's what I want to give people. I'm going to type into the chat my email address. So.
And while she's doing that, I'd just like to kind of add on to John's question and Kathy's point about Medicaid expansion and remind everyone that in Missouri, Medicaid expansion will be on the ballot in August as a Missouri constitutional amendment. So to the extent that we have talked about the role that Medicaid plays and the importance that funding stream holds for providing long-term care, it's worth noting that Missourians will have an opportunity to vote for expansion and come August.
Thank you, guys. Great program. Great program. Thank you. It's a tough topic.
Oh, Kathy, I think your email your email address maybe went to just the panelists. So I'm going to.
Oh, okay. Sorry.
Send it to everyone.
I can do it. I'll change it.
Okay.
I know you three have my email. Thanks for noticing that.
Yep.
I have a state of Kansas email address again.
All right.
It had been 11 years. Mm-hmm. Yeah.
All right. Well, thank you, Carol and Kathy, for this excellent program. And thank you, John, for your contributions as well.
Sure.
Just a reminder to everyone who is on today, these sessions are recorded and you can find the recording on our YouTube channel. So if you go to YouTube and search for Practical Bioethics, you'll be able to find that, as well as all of the other episodes that we have added to this pandemic series. So I think the next one we have will be in July, and we'll be taking a break from the subject of COVID, and we'll be talking about neonatal diagnosis with Dr. John Yeast. So keep an eye out for information about that, and we will see you on the next one. Thank you, everyone, and have a good day.